Acute leukemia, acute lymphoblastic leukemia and acute myeloid leukemia. Etiology. Only in some cases are etiological factors identified. These include environmental agents as well as host susceptibility. Ionizing radiation. This was discovered following the increased incidence of leukemia after nuclear disasters, particularly acute myeloid leukemia, AML. The suggestion that the incidence of acute lymphoblastic leukemia, ALL, is increased in children living near nuclear power installations remains suspected but unproven. There is no definite evidence for increase in those exposed to modern diagnostic X-rays, except infants exposed to radiation in utero. Chemicals, benzene and alkylating agents, used to cure a prior malignancy. Viruses, human T-cell leukemia or lymphoma virus is directly implicated in adult T-cell leukemia or lymphoma. Genetic factors, Down syndrome, Bloom syndrome, Fanconi's anemia, and being the child of a nuclear power plant worker. Acquired hematological abnormalities. This includes conditions that may transform into acute leukemia, e.g. myeloproliferative disorders, aplastic anemia and myelodysplasia. Epidemiology. ALL is largely a disease of the young, peak incidences in those aged 4-5 years. It is well recognized in adults and in infants, although less common. In contrast, AML is predominantly a disease of adulthood and the elderly. There is no geographical variation, except where the etiological factors mentioned above play a role. Clinical presentation. The history tends to be short. Symptoms and signs can be grouped as shown in Table 14. Investigations. Blood film. The diagnosis will frequently be suggested by examining the blood film thoroughly. The white cell count may be high, normal, or low, but in many cases blasts will be apparent. The distinction between lymphoid and myeloid malignancy may not be obvious at this stage, unless particular morphological features are found, e.g. our rods in AML, Fig 24. Bone marrow aspirate and trifine. The marrow is hypercellular with numerous blasts, usually well in excess of 50%. Morphological distinction can be made between ALL, Fig 25, and AML, and the subtypes within each category. Cytogenetics. Certain entities of the disease are strongly associated with recurrent chromosomal abnormalities. As well as aiding in diagnosis, these may also confer prognostic value. The T15, 17, translocation of promyelocytic leukemia confers good prognosis, but the T9, 22, translocation of ALL confers a poor prognosis. Immunophenotyping, cell markers. These techniques are helpful in identifying particular cell types and their clonality. AML is then subclassified into 8 subtypes, M0 to M7. Cytochemistry. These stains are useful in identifying the lineage of the leukemia. Treatment. NB. If you are unsure about a diagnosis of acute leukemia and the treatment options, ask for help before discussing the diagnosis with the patient. Your local hematologist is likely to take over care of the patient and should be involved early. When explaining the diagnosis, especially for the first time, try to ensure that the patient has some support available. Remember that in some cases you will be explaining matters to the parents of the patient. Individuals will respond to this news in their own way. Try to be supportive. Most hematology departments will have booklets and numbers to call for further counseling or information. The treatment in almost all cases will involve periods of prolonged hospital admission, as well as periods at home with frequent hospital attendances. Not only will the patient's life be disrupted, but also family life as well. Do not neglect the schooling, working, social and financial aspects of the care of these patients. In all but the very elderly or unfit, intensive chemotherapy is the treatment of choice, at least in the first instance. In all patients, the insertion of a long-term indwelling central venous catheter is indicated, Fig. 26. This facilitates the administration of chemotherapy and the sampling of blood. However, it is associated with risk of infection and thrombosis, and its care should be scrupulous. NB. In an adolescent or adult of childbearing age, the likelihood of infertility following chemotherapy should be discussed and semen or ovarian cryopreservation offered. Adequate precautions should be taken to prevent infections both during and after chemotherapy. Prophylactic oral antimicrobials should be given to sterilize the gut. A diet free of yogurt and soft cheese is necessary. Thrombocytopenia will cause a fatal hemorrhage, so platelets should be given prophylactically when counts drop below 10x109/L. A platelet count of more than 20x109/L associated with minor bruising is not generally treated and a watch and wait policy is observed. However, a platelet count of less than 20x109/L with mucosal or severe bleeding is generally actively treated in order to raise the platelet count to more than 50x109/L. Intracerebral and intraocular bleeding and surgery should be treated to achieve and maintain a platelet count above 100x109/L. The principles of management differ according to the diagnosis. Acute lymphoblastic leukemia. Combination chemotherapy is used. This induces remission and then consolidates with stronger chemotherapy. Certain aspects of treatment should be noted. Central nervous system, CNS, therapy. In all patients with all, prophylactic treatment should be given. Prior to this being routine, there was a high incidence of CNS relapse, probably due to the inadequate eradication of disease. The CNS is a sanctuary site and many drugs cannot cross the blood-brain barrier. Maintenance therapy, continuous treatment for up to 2 years has been shown to increase disease-free survival. Acute myeloid leukemia. Treatment usually consists of 4 to 5 courses of intensive chemotherapy, each lasting 5–10 days. Maintenance therapy has not been shown to be of benefit. Special situations include the following. AML-M3. Due to the high incidence of DIC found in this subtype of leukemia, these patients should be managed aggressively with platelet and clotting factor support. The chromosomal translocation that is characteristically found makes the disease responsive to treatment with all trans-retinoic acid, which is started prior to the administration of chemotherapy. AML-M5. Due to the higher incidence of CNS disease in this subtype, prophylactic intrathecal chemotherapy may be indicated. In both ALL and AML, the indications for autologous and allogeneic stem cell transplantation are well established. Complications. These occur in the long-term survivors of therapy, mainly children. Secondary malignancy. Neuropsychological effects. Endocrine dysfunction, children especially. Infertility. Cardiac and respiratory sequelae. Prognosis. Acute lymphoblastic leukemia. In childhood, good risk disease has a long-term disease-free survival with chemotherapy alone of 60–80%. This is only 20–30% in poor risk disease. The risk factors are shown in Table 15. In adult ALL, survival mimics adult AML. Acute myeloid leukemia. Disease-free survival with chemotherapy alone is about 40% in good-risk disease, favorable cytogenetic abnormalities, younger age, and no evidence of pre-existing myelodysplasia. Allogeneic bone marrow transplant can be curative in younger patients, younger than 50 years. However, the majority of patients over 65 years of age have a median survival period of 2 years.